Hello everyone, here is a quick video for the medicine formulas. So, first of all, remember autosomal dominant polycystic kidney disease 1 is related to chromosome 16, type 2 is related to chromosome 4, and recessive polycystic kidney disease is related with chromosome number 6. Then for renal tubular acidosis, it is of 3 types: type 1, type 2 and type 4. In type 1, proximal part of the nephron is involved. In type 2, distal is involved. In type 4, there is aldosterone deficiency. Then remember the Cockcroft and Gault formula for estimated Gfr calculation. So remember this formula, it is 140 minus age multiplied by weight upon divided by 72 into serum creat. And for females, you need to multiply this value by 0.85. So this will give you the estimated GFR. Now, chronic kidney disease. It is gradual decline in GFR more than or equal to within 3 months. So that is the cutoff, and most common chronic kidney disease in the world is diabetes mellitus associated nephropathy. Now, remember, you will be given a clinical scenario like for Alport Syndrome. There will be clues in the question will be recurrent hematuria, sensory neural hearing loss, and anterior lenticonus, which is the most specific and most common eye related is dot and fleck retinopathy. So answer to that question will be Alport Syndrome. These clues will be given, and it is X-linked inherited defect, and it has good graft survival. Then iron deficit calculation formula is 2.4 into target minus the actual HB of the patient into weight plus 10 milligram per kg. Then for sodium correction, you have the formula 0.6 into body weight multiplied by target minus serum sodium, and for females, instead of 0.6 you multiply it by 0.5. Then remember the normal values. For pH it is 7.35 to 7.45. For PaCO2 it is 35 to 40 mmHg, and for bicarbs it is 22 to 26 milliequivalents. Then now for acid base disorders, remember the mnemonic is ROMS, respiratory opposite, metabolic same. The change in pH will be in opposite direction to bicarbs and PaCO2 in respiratory, and all three will change in same direction in metabolic. So let's talk about respiratory acidosis and alkalosis. So in acidosis, the pH has decreased, but PaCO2 and bicarbs will increase. So how much it will increase? If it is acute, for every 10 mm increase in PaCO2, bicarbs increase by 1 milliequivalent. And for chronic, for every 10 mm increase, the bicarbs will increase by 4 milliequivalents. So you'll remember it like 10 to 1 and 10 is to 4. Now for alkalosis, pH has increased, but PaCO2 and bicarbs will decrease. So for every 10 mm decrease in PaCO2, bicarbs will decrease by 2, and in chronic, for every 10 mm bicarbs will decrease by 4. So remember this. Now let's talk about metabolic acidosis. So the expected PaCO2 will be 1.5 into bicarbs plus 8 plus minus 2. So you'll get the value of expected PaCO2. For this is known as the Winter's formula, and for metabolic alkalosis, expected PaCO2 will be bicarbs plus 15. So in metabolic acidosis or alkalosis, if pH decreases in acidosis, so bicarbs will decrease and PaCO2 will decrease. All the change will be in the same direction, and in alkalosis everything will increase. Now the formula for urinary anion gap is, sodium plus potassium, then minus chloride. Then anion gap. Normal anion gap is 8 to 12 milliequivalents. The formula is sodium minus chloride plus bicarbonates. This is within the brackets. Now, if you see anion gap is present in metabolic acidosis, so to rule out mixed acid-base disorder, you need to see the delta gap. Now, what is delta gap? Delta gap is change in anion gap minus change in bicarbs. This is one of the previous year AIMS question. So, change, how will you calculate? It is measured minus 12 and change in bicarb is 24 minus the value given. So, if the answer is like minus 6, so you have mixed disorder, mixed normal anion gap metabolic acidosis with high anion gap metabolic acidosis. If it is minus 6 to plus 6, then it is high anion gap metabolic acidosis. And remember, if it is more than 6, then you have hagma with metabolic alkalosis is present. Now this point is also one of the previous year. What is Kaplan syndrome? It is rheumatoid arthritis with pneumoconiosis. What is oliguria? When the urine output is less than 400 ml per day. Anuria is when the output is less than 100 ml per day. Now Felty syndrome, this is also one of the previous AIMS question. It consists of rheumatoid arthritis with splenomegaly with neutropenia. Now in one of the question, if you have given like diastolic blood pressure is increased, so you need to check if edema is present. If it is present, then it is hypothyroidism. If it is absent, then it is Conn's syndrome. So these are the important points. Thanks for watching. Kindly like, share and subscribe.